I am Dr. Richard Gutler, board-certified endocrinologist and interventional thyroidologist in private practice with a special interest in non-invasive methods to decrease unnecessary thyroid surgery. In 1974, when I entered practice, virtually 100% of symptomatic or cosmetically challenged nodular goiters were subjected to thyroid surgery. Only 5% were cancer, and many had lifetime complications even when a benign diagnosis was made post-surgery. Over 50 years, I've seen numbers of thyroid surgery decrease to the present 150,000 per year in the U.S. Still, 1/3 or 50,000 are done on benign nodules. Today, I'm showcasing thyroid radiofrequency ablation for benign thyroid nodules in the USA. Until 2018, I have seen many patients with benign thyroid nodules to have RFA in Italy or Korea. I have had personal experience training on 3 different RFA systems in my office, attended training in Italy and Brazil, and I did my first human case in Brazil. Thermal ablation works by ionic agitation and formation of friction heat. Tissue ions are agitated by the application of alternating electrical current. Ion agitation results in ion friction, which in turn causes heat production. Heat propagation through the target tumor. Immediate tissue coagulation necrosis is achieved by friction heat generated and in the vicinity of the electrode, but electrode remote tumor tissue ablation more slowly via conductive heat. Heat friction is more powerful than conduction heat, but the ablation range by friction heat is very narrow, limited to the area of the electrode. An example of ablation that can be obtained: a solid nodule on the left before RFA and during ablation and after 50 months. And the yellow circle is the reduced nodule, 97%. The necrosis of the nodule is seen in the bottom 2 images. Here's an ultrasound showing the complete ablation of the nodule by ultrasound method. Recent FDA allowed us in the US to do thyroid nodule radiofrequency ablation. This patient is a patient that has a large thyroid nodule that's causing her local symptoms in her neck and is cosmetically unattractive. The patient was selected for thyroid RFA because she had symptomatic benign nodule and had a cosmetic problem. Symptomatic and cosmetic scores are recorded before and after radiofrequency. The need to have benign prior needle biopsy, normal thyroid tests, and clotting screen before we accept as a candidate. Any serious comorbidities are recorded. A pre-RF image is taken of the neck along with a video. Neck ultrasound image is in the next slide shows a 10 millimeter volume thyroid nodule before treatment. In addition to patients with large class 2 benign cytology, patients with indeterminate biopsy result need molecular marker testing before considering surgery, as many have negative marker tests. These can be treated with radiofrequency ablation instead of surgery. Thyroid RF systems have a generator, a short 7 centimeter, 19 millimeter gauge monopolar electrode with a 5 to 10 millimeter hot tip. A cooling pump with ice saline and 2 grounding pads are added to the thighs. The method of treatment was entry through the isthmus. That's called trans-isthmus approach. There are few blood vessels in the isthmus area. However, careful Doppler images are still needed to be sure the entry is clear of blood vessels. The electrode is positioned in the different sections of the nodule and the heat is applied. This is called moving shot ablation technique and is used with careful ultrasound guidance. The closer to the recurrent nerve, the less ablation, and as you move into the center of the nodule, the ablation zones are increased. Except for local lidocaine injection of the entry point skin and the thyroid pericapsular space, there are no general anesthesia or conscious sedation. There are no nerves in the thyroid, only in the capsule. The next slide is of the needle in the thyroid gland pericapsular space. And you can see the needle coming in from the right, and the dark area is the injected lidocaine, making the capsule have no pain when you're doing the treatment. The next slide shows the microdissection technique with dextrose infusion. Do not use saline as it can conduct electricity, while dextrose does not conduct electricity. It is used in some cases where the nodule is in close proximity to a vital structure. In this example, it's up against the carotid artery. Injected dextrose fills the space between the nodule and the carotid artery. You can clearly see the two arrows separating the carotid artery on the right with the nodule on the left. The next slide, examples of dextrose microdissection seen in this cartoon. First, the E one shows dextrose protecting the recurrent nerve, the G cartoon protecting the carotid artery, and the F and H collar around both nerve and artery. Complications occur with any procedure, but radiofrequency ablation for thyroid is amazingly complication-free. The goal of thyroid RFA is to relieve symptoms and cosmetic problems with least amount of complications. The next slide depicts all the possible complications. The majority are minor, 3%, and temporary, such as pain and bruise. Serious complications are 1%, such as temporary voice changes. Nodule rupture and abscess formation are extremely rare. Hematoma is usually controlled by compression and rarely needs transfer to the hospital for observation. Proper placement of the grounding pads on the thighs makes it unlikely to get a skin burn. What are the results of thyroid RFA therapy? The slide shows my patient before and after of a nodule that had decreased from 89 ml to 6 ml. Her symptoms and cosmetic scores were corrected to 0 after the treatment. Long-term results of this patient has shown complete control of her nodule at 3 years. Here is the second case where the patient had a 16 ml nodule with a score of 6/4, and after therapy it had decreased to 5 ml and a 68% reduction, and the scores, the symptoms, and the cosmetic enlargement were 0. This is the beginning of my discussion of the actual procedure. How is office thyroid RFA done? The slide shows the arrangement of the room. The patient has their head in a donut at 6-degree elevation and has a blindfold or can elect to watch from an overhead mirror. I am at the head of the table facing the generator at the foot. There are 2 screens, and the sonographer stands on one side of the patient and monitors the ultrasound and the insertion direction of the electrode on one screen while I monitor the other screen and the generator. I am Dr. Richard Gutler, board-certified endocrinologist and clinical thyroidologist in private practice with special interest in non-invasive methods to decrease unnecessary thyroid surgery. Today, I'm showcasing thyroid radiofrequency ablation for benign thyroid nodules. This simple outpatient procedure is done in my office without general anesthesia, conscious sedation, just local anesthesia. The patients are selected for thyroid radiofrequency when they have symptomatic benign nodule or cosmetic problem. They need to have a benign prior biopsies, normal blood tests, and clotting screen. A pre-radiofrequency image is taken of the neck. The ultrasound is used to evaluate the nodule and to locate the areas where vital structures are located. These include the vagus nerve near the carotid artery, the recurrent nerve, the trachea, and the common carotid artery. The danger triangle medial to the thyroid gland contains the recurrent nerve. Also, it is used to make sure the electrode entryway through the isthmus is clear. The radiofrequency room has a patient table, an ultrasound, a generator, ice water pump, an on-off foot pedal to control the hot tip. The generator has adjustable watt control, and there are 2 grounding pads to apply to the patient's thighs. There's an oxygen sensor, blood pressure, and pulse monitoring system by the roving nurse. Standing emergency tray has ice saline for any voice changes, Tylenol for pain, and anti-nausea medications. The RF medical system includes the generator, the ice water pump, a power source, off-on foot pedal, grounding pads, and the electrode. The electrode is only 7 centimeters long and has a thin number 18 gauge needle with a hot tip of 10 millimeters. This is ideal for working in the small space of the neck. The ice water from the pump circulates around the electrode to keep the rest of the electrode cool. The patient has their head in a donut at 6-degree elevation to prevent aspiration, and has a blindfold or can elect to watch from an overhead mirror. I am at the head of the table facing the generator at the foot of the table. There are 2 screens, and the sonographer stands on the patient's side and monitors the ultrasound and the insertion direction of the electrode on one screen while I monitor the other screen and the generator. My sonographer helps locate the best position in the nodule, and after I am satisfied that the location is safe, I activate the heat with the foot pedal. When significant ablation occurs, I use the foot pedal to turn off the heat. This is done over and over to different areas of the nodule until the total volume is covered. This is called moving shot technique. My nurse is monitoring the patient's voice and any symptoms during the procedure. She also records vital signs and can, on my directions, adjust the wattage. The superior and inferior extent of the nodule is marked with a red marker on the patient's neck. The midpoint of the nodule is marked with an X as the entry point. The thyroid capsule has sensory nerves that can cause pain. I inject 1% lidocaine along the outside pericapsular space of the thyroid capsule before I start the ablation. Also, the cystic fluid, if present, is drained before the radiofrequency treatment. The electrode is inserted through the isthmus in a direction medial to lateral away from the recurrent nerve in the danger triangle. This is called transisthmic approach. The procedure uses ultrasound guidance to position the electrode in a series of places in the nodule, usually from inferior posterior to inferior anterior in each section of the nodule during the serial 10 millimeter ablation zones. This is called moving shot method. It can usually take 30 to 45 minutes. Ultrasound images show the area of ablation by hyperechoic echoes, whitish in color. The electrode is then moved to a different area. Caution is taken not to get within 5 millimeters of the capsule while the electrode is activated. The post-radiofrequency ultrasound images will show the areas in the nodule ablated by the hyperechoic whitish pattern. The patient is observed for 15 to 30 minutes and then returns to the examination room. Questions are asked about how they felt during and if they have any side effects. The picture and a video of the neck is taken. The patient returns at 1, 3, 6, and 12 months for an ultrasound and repeats symptom and cosmetic questionnaire and scores to compare to the pre-radiofrequency score. A well-trained interventional endocrinologist is, in my opinion, the best physician to do thyroid RF because they know their patients. But radiologists, ENT, and surgeons can also do thyroid RF, but may be more expensive due to a hospital-based treatment. Thyroid RF can cost anywhere from $5,000 office-based to $25,000 for general or conscious sedation in the hospital. Thank you. The thyroid RFA can usually take 30 to 45 minutes. The thyroid RF is a procedure easily learned by AACE and ECUN certified endocrinologists who do their own ultrasound and biopsies. With their vast knowledge of thyroid disease, they seem to be the ideal operator for thyroid RF. Other specialties are also doing it, including surgeons, ENT, and interventional radiologists. The cost of endocrine office-based thyroid RF is less than hospital or imaging centers. The estimate for different sources is thyroid RF costs $25,000 to $30,000 in the hospital with general anesthesia, or $15,000 with conscious sedation. Data from major medical centers. Endocrine office-based thyroid RF from several sources is $500 to $7,500. Training programs are available in Brazil, Korea, Italy, and in the USA. One program is my 1 to 2 day master's class with observation of a patient of mine having thyroid RF of their thyroid nodule. One program in Brazil allows qualified physicians from other countries to do a patient under supervision. I strongly recommend a visit to see Dr. Rangel in Rio and take his advanced course. I did it and it made me aware of how relatively easy the procedure, not much more than well-done ultrasound-guided biopsy or ethanol ablation procedure. The next slide, all the RFA countries use lectures to teach hands-on training with bovine liver, turkey breasts, and gelatin models to teach thyroid RFA. Most do a live observation of an instructor doing an RFA on their patients. This is an example of a beef liver that was inserted in the bovine liver and ablated by my student, and you can see the whitish area is the ablation and the reddish area is the normal beef liver, showing the ablation did not exceed the size of the nodule. This is the method to train them. They need to do 50 bovine livers to be able to be good enough to consider doing it on a human. The next slide shows a graduate of my thyroid RFA master's class. 2 studies by endocrinologists appeared in the Journal of the Endocrine Society this year. My study results are on the next slide. Similar good early results are seen in the second study from my fellow interventional thyroidologist in Utah. The nodules varied in the decrease in volume at 3 months. However, symptoms and cosmetic scores improved in each case, except for the local pain after the procedure. There were treated with Tylenol. There were no serious complications. One patient received a Medrol dose pack that helped with her tender neck pain. The goal of thyroid RF is to relieve symptoms and improve cosmetic problems, not to make the nodules disappear. Early relief of symptoms and cosmetic problems at 3 months is a good sign that we are approaching our goal in the study. There are no serious complications and only minor ones. 9 patients at 3 months. The pre-RFA mean volume was 55 ml, and they ranged between 16 and 127. The mean volume reduction, 47%, and the reduction was anywhere between 15 and 67%. Patients with incomplete treatment at 3 months, 37% decrease at 3 months. Symptoms decreased from a score of 8 to 3, but the nodule was still visible, cosmetic score still 4. Here's an example, 67% reduction in 3 months. Before, the symptoms were 8 and the cosmetic score was 4 and the volume was 114 ml. 3 months later, the scores were 2 and 3 and the volume had decreased to 37 ml. The preliminary study of thyroid nodule patients with benign nodules showed how thyroid RFA can be safely done in the scope of an endocrine office practice. This is based on the need for any endocrinologist to be trained before doing any thyroid treatments on humans. The preliminary studies from the US continue till 12 months. This is early, hopeful evidence that large clinical trial of 80 to 120 patients from several trained endocrinologists doing thyroid RF in their office is needed to validate the procedure. Thank you.